Kathy Greenwood, and Kathy's going to be talking about the I2 research project. And Kathy's going to be kind of leading us through some of the work that they've done around the use of routine outcome data collection and what have been some of the difficulties about collecting that. Now, although Kathy's going to be talking about this from a research project, it's important to understand that the I2 project uses, for its prime outcome, it uses the outcomes that we generate in EI. So it relies on us collecting the data on the QPR and the DIALOG and the HONOS. She's done a huge amount of work around trying to understand what have been some of the difficulties around people routinely collecting data, and Kathy's going to talk us through some of that. Then we've got, Kathy and Maureen are both on video, so we're going to play some video material. Maureen is a QI consultant who's worked with the Royal College of Psychiatry over a number of years, and Maureen's going to talk us through some QI kind of strategies.
Hello, my name is Kathy Greenwood, and I am from Sussex, the University of Sussex, and Sussex Partnership Foundation Trust. So I'm speaking to you from sunny Brighton. So I'm going to be speaking to you today about supporting the collection of routine outcome data in early intervention in psychosis services. So I'm going to cover 5 core areas. Firstly, the value of using outcome measures in general, and then I'm going to be talking about some of the work that we've done to understand barriers to collecting outcome measures, and the strategies that we've discovered for overcoming these. I'm going to talk a little bit about how to implement the measures reliably in practice, and lastly to talk about scoring. So the work that we're going to be referencing today has come from a project called the I2 project. This is the project that is running in early intervention services around the country. It's a national project that we're leading from Sussex. And I2 stands for Early Youth Engagement in First Episode Psychosis Study. It's a cluster randomized controlled trial. And what we're looking at is the effectiveness, cost effectiveness, and the implementation of a team-based motivational engagement intervention in early intervention services. And the reason this is relevant is because we are evaluating the effect of this intervention, both in terms of engagement and disengagement, but also in terms of the routinely collected outcome data in early intervention services. So that is looking at the HONOS, the questionnaire on the process of recovery, the QPR, and the dialogue in 950 first episode psychosis service users around the country. So we're a national team, national early intervention leads, clinical academic and psychosis leads from around the country, particularly Manchester, London, and the south of England. And we've also got lots of involvement from other types of researchers, including patient and public involvement leads, so service users, implementation leads, and our statistics and qualitative analysts. And everybody has been coming together to particularly think about how we can reliably and robustly collect routine outcome measures in early intervention services around the country. So before we start thinking about how we collect outcome measures, it's worth spending just a moment to think about what your own or your team's values are. So what are the things that you as an individual and you as a team within the NHS and within early intervention services are striving for? What are you trying to achieve? And then what we're interested in is to think, how do these values fit with collecting early intervention routine data? So some of the things that we've been hearing as we've been going to teams around the country are things like the importance of being flexible, of being engaging, of being creative, the importance of being empathic and person-centred, but also the importance of being evidence-based. So we're going to come back to some of these issues as we go through the presentation. But before we do that, I think in talking about the value of using outcome measures, it's important to listen to service users themselves. And I've just taken a couple of brief quotes that have come from service users who helped us with the training around the country. So this is a quote from Ellie from Manchester. So I felt a bit overwhelmed and hopeless. And I think the questionnaires can really help you to notice that something has started to get better, even if it's just a little bit, and even if it's just a one question. And Ben from London. So Ben was asked by one of our EIP staff members, how do you feel when we ask you to fill in these really boring questionnaires? And Ben said, well, actually, I don't think they are really boring at all. I remember filling some in when I first started with early intervention, but actually no one shared the results with me. And I'd really like to do them every month so I can see how I'm getting on. So these were just a couple of the quotes that we got from service users as we travelled around the country doing our training. We also had a team leader who said, I was pretty sceptical, to be honest, but then I was working with someone who kept missing our sessions. I really didn't get it as her housing was really bad. I was trying to help. I had to do the dialogue with her. And then I discovered that from her perspective, her housing was actually the best it had been for ages. And her main problem was something completely different. That's why she wasn't meeting me. So outcome measures gave us the opportunity to notice something that otherwise we might have missed. So those are just a few of the quotes that we've collected as we've been doing the training. And here are some other points that are relevant to the value. So they can provide additional information for care planning. They make sure service users' voices are heard. So if somebody's quite quiet, it can be an opportunity for them to just tick a box, but it shows how they feel. It shows it's possible to show and improve clinical outcomes. So we touched on evidence-based practice a moment ago. It's possible to evaluate our practice and improve on it. It's possible to use these to enhance shared decision-making, improve collaborative practice, reduce dropout and disengagement, as we were hearing from the team leader a moment ago. It improves the ability to detect relapse and notice the early signs that things are shifting downwards. Service users, in the most part, like them, as long as we're kind of flexible and creative about when we use them. And they can actually inform team development if we know that there's an area where lots of service users have said they'd like more input. We can do a little bit more work and team training around that. So what about the measures themselves? I'm assuming that you're familiar with these measures. They've been developed by an expert reference group, and these are the DIALOG, the Process of Recovery Questionnaire, and the HONOS, the Health of the Nation Outcome Scale. So it's those three that I'm going to be talking about. And particularly, I'm going to focus on the patient-reported outcomes, the DIALOG and the QPR, because those are the ones that are the newest and the ones that we need to work most to embed in our services. So what are the barriers to collecting these outcomes? As I say, we've been working with clinicians initially in Sussex, so we did some pilot work in Sussex, and then around the country, identifying barriers that might get in the way of using these measures and then trying to overcome some of those barriers. And again, it might be worthwhile for you to just note down for a moment the key barrier for you or members of your team. You know, what gets in the way of using a patient-reported outcome measure? So some of the feedback we've had is not enough time. Time is a big barrier. We're all really busy. And there's not enough time always to complete these measures in the session. There's too much to talk about. They might drop to the bottom of the agenda. And the challenge is that they drop to the bottom of the agenda on the day that you intended to do the measures, and then other things take over, and before you know it, months have gone past and you've not completed them. Another challenge is the barrier of some of the clinical barriers. So collecting outcome measures might not be your highest priority at a particular time point. There are other things that you might need to consider in a session. There's lots of paperwork to complete. We've been hearing about that around the country. And particularly, you might feel that the measures have little therapeutic value, and that they might even hinder the therapeutic relationship. I've heard from some people in teams around the country who've said, we've been collecting the HONOS for 10 years, but it's not used for clustering and early intervention, and nobody ever uses it. Well, now is the time that we're starting to use those measures, so that your scoring and your work on this really makes a difference. And some people have said, if there's no history of previous score, you've got nothing to compare the patient's progress with. And again, that's a good reason for collecting more than one outcome. There may be a barrier for service users. So service users may not want to complete measures. They may be suspicious of why we're using those. And that's particularly tricky if somebody has an acute mental health issue. So if they're feeling overwhelmed, they're struggling to concentrate, they've got cognitive difficulties that might make it hard to kind of pay attention to the measures. And also if they might see them as not particularly useful or valuable. Another challenge, of course, is language barriers that can make it harder to complete. So we're looking into whether we can translate some of these into other languages. So what are the strategies for overcoming some of these barriers? So the first is about overcoming time challenges. So you might want to actually start a session with the measures themselves, and then almost let the results of the questionnaires guide the rest of the session. So use it as a bit of a kind of goal-setting session. It's a bit less crisis-led then, and it also shows that we're embedding the measures in what we offer. You might want to consider placing paper copies in waiting rooms or posting them out to service users. Now, some people might be able to fill them in on their own, and that could be valuable. But the other thing service users have told us is they quite like time to look through the measures first and think about what their response might be before they're asked to fill it in, so that they're not kind of put on the spot. So it could be helpful for a service user to be able to look at the measure first and then complete the measure with you together. Teams have told us that they need lots of reminders. Things easily drop to the bottom of the agenda. We're juggling lots of stuff all of the time. And so reminders in team meetings, on phones, in Outlook diaries, having Excel spreadsheets set up with a reminder of when an outcome measure is due, putting posters up around the place. The other thing people have said is having the measures by the in-out board that you might have in your team that you sign out of as you leave the building, and perhaps having a string of measures there so you can remember to just grab one as you go out. We've even had one team in Sussex who had therapy dogs, renaming their therapy dogs, obviously, with a sense of humour, as QPR and DIALOG, which then reminded everybody to collect the outcomes. So there are other challenges for a clinician to overcome. So you might want to think about how you introduce the measures. And for that, I come back to the question that came to Ben, the service user, in one of our trainings. So he was asked, how do you feel about these boring outcome measures? It's worth remembering that these might not be boring to service users. In order to keep up with outcomes, we might need to actually collect them nearly, probably as much as 1 or 2 a week, which could feel a bit boring. But for service users, they might actually be quite positive. So apologising as you hand the outcome over or the questionnaire over might minimise the value of it. Whereas using it to frame the session, describing the importance of it, can really make a difference, and you can bring the results into the session to help kind of evaluate how you're getting on, what the priorities might be, and use it for care planning. So here are a few ways to introduce the measures. So we use these measures with everyone who uses early intervention services across the whole country. They've been designed by service users. They can provide some really useful information about you and how you're getting on at the moment. They're 2 questionnaires. We might try to complete these about once every 6 months so we can keep a track of how things have been going. I'm not sure if you remember filling these measures in a while ago. If you could fill them in again now, we can have a look at what's changed for you in the last 6 months. These are 2 questionnaires that can help us understand your feelings about your goals for recovery, about what you want to achieve, and how we might be able to support you. Or these are 2 questionnaires that can help us to just get to know you and what matters to you. You can fill them out by yourself, or I can help if you want. So just trying to kind of think about how we introduce the measures, and then also to think about how we use them. So this is an example of a completed dialogue questionnaire from a service user. So take a moment to just have a look and think, if this was your service user, how would you use this to plan care? So the first thing that you're noticing is they're feeling very dissatisfied with their job. So some kind of vocational support, volunteering work might be helpful. And they're also feeling fairly dissatisfied with their mental health, their accommodation and medication. So getting some accommodation support, a discussion with pharmacist or psychiatrist, and offering some further options for mental health support, whether that be psychology, increased care coordinator support, psychiatry session, family interventions. So all of these could be kind of goals or areas of focus for the next few months for this service user. Similarly with questionnaire on the process of recovery here, if you have a look at this, how would this influence your care planning with this individual? So what you can notice here is that there are a number of different areas where the person disagrees, i.e. they're feeling less well on the journey for recovery, around feelings about themselves, their self-esteem, their sense of purpose, that we might want to be working with psychologically or vocationally. They've also got some areas that they're less far forward with in terms of their recovery journey, in terms of feeling that they belong in society and that they've got positive family relationships. You might want to think about social groups, family interventions, OT or support worker support to increase their kind of meaningful activities. And also kind of drawing on strengths as well. So this person's mentioned that they are strongly motivated to get better, and they can find time to do things they enjoy. So they've got some strengths there. It's worth remembering the strengths as well. So we can use the dialogue to help us identify just a broad area of dissatisfaction across mental and physical health, job, accommodation, leisure, relationships, and treatments. But then we can use the QPR to actually identify some of the factors that might be underpinning their dissatisfaction. So what are their beliefs about their life, their self, their social skills? What's their motivation, their outlook? How do they feel about their abilities? So we can actually get different types of information from each of these questionnaires that help us to identify the service user's goals. And then we can use those measures in practice to set goals and to monitor progress in meeting those if we collect the same measures over more than one time point with the same service user. So this is where we start to become creative, to become flexible, to become person-centered, to be engaging, to be collaborative. So we're now overcoming some of the service user challenges, So one of the most important, perhaps, is to be flexible and be engaging. So as I'm sure you know, it's probably not the time to do these questionnaires if somebody's in the middle of a crisis. But it's important to be engaging, to give people opportunities to return to these questionnaires later. As we heard from Ben, he did the questionnaires once early on, but then never again. We want to be empathic, so talk through with service users and make sure they understand and help them to complete the measure. We want to be collaborative in that respect, so explaining the importance and reaching some kind of sense of conclusion about the service user's goals. We want to be open and transparent and provide feedback with scores that we might discuss in the session, so you can produce, with your team, you can produce graphs and so on and share the results, or even just kind of discuss them on paper. And just be really creative about how to collect them and how to use them and how to embed them in the work you do and how to really kind of demonstrate the value and the importance that these can bring. You might want to simplify the measures and make them accessible. So we have made them, as you can see in this picture here, we've made them colourful, we've put them into double-sided packs, we've got them in pads of 25, we've made a space at the bottom so that if your service user has extra things that they want to say when you're doing the questionnaire assessments, you can include that in there. We've got a flap that kind of parts across the middle so that we can ask somebody, for example, in the dialogue, are you slightly more satisfied or dissatisfied with your physical health, for example? And then we can cover up half of the questionnaire, which you can see on the picture on the right, so that they then only have to choose from 3 options. Are they fairly, very, or totally satisfied? We've got a smiley face scale without the words on the top, if that's easier. And we've also developed some explanations for some of the QPR items that might be harder to explain. So some people have said some of the QPR items might need a bit more explanation, and it might help to use some of them in different orders, so you don't have to start with question 1. So some people have said it's harder to start with asking somebody about satisfaction with their mental health on the dialogue, if maybe they don't think they have a mental health issue. And it might be hard to ask somebody if they feel better about themselves when you're only seeing them for one of the first few times on the QPR. Although it's worth saying that question about I feel better about myself and all the other QPR questions are related to the last 7 days. So have you felt better about yourself in the last 7 days than before that? We have a manual which you can download, which tells you more about all of the things that we've been discussing today, and gives you some information about how to describe the QPR items. So now just coming on to a few other tips for implementing the measures. Setting targets. We found in discussion with our service manager in Sussex and other sites that setting achievable targets in a time frame can actually be really helpful, because as we were talking about, there's so many things going on. We're so busy, things can slip for kind of months at a time quite straightforwardly. So setting a target to maybe increase the proportion of the caseload with an outcome measure by around 20 to 30% over 3 months has seemed to be quite realistic. We might want also to think about other strategies like providing monitoring and feedback, posting out the measures, completing them over the phone. This is another thing that we found has actually been received a lot more positively than was expected, and that service users, in the most part, are really quite happy to complete measures over the phone. Lots of reminders, so posters in the office, posters in meeting rooms and waiting rooms, goal setting sheets that I'll show you in a moment, service user feedback forms so that you can use graphs to share outcomes and changes over time. So these are just a couple of other measures, printouts that are in the manual if it's helpful. You can see a dialogue and QPR goal setting form on the right side there. And just as an example, this is what was happening in Sussex when we started applying some of these approaches. So we had somebody who started to work with the team in late July, and this was the graph of the number of completed outcomes on QPR and DIALOG after that. So lastly, just a quick mention about scoring. The QPR has ratings for disagree strongly to agree strongly. So when you're scoring this, you allocate a point depending on the option that the person's ticked. So disagree strongly would get 0, disagree 1, neither disagree or agree 2, agree 3, and agree strongly 4. And then you add the scores up to make a QPR total score. So as you can probably imagine, if somebody scored disagree strongly for everything, they would get 0. If they scored agree strongly for everything, they would get 60. So the range is 0 to 60. So a paper by Williams and colleagues in 399 people with psychosis, and this was older people, an average age of 44, had a mean on the QPR total of 38.7. So that's about the mean in a longer term psychosis sample. It's also got good psychometric properties, and we're looking now at scores in a first episode psychosis group with the I2 project, and we'll be able to share those shortly. The DIALOG also scored in a similar-ish way, but this time the score ranges from 1 to 7. So totally dissatisfied gets a score of 1, through to totally satisfied gets a score of 7. And scores on the DIALOG can be clustered into 2 scores, and they're both average mean scores. So the first 8 items you add up and then divide by 8 to give you a mean score for subjective quality of life. And then the second score from the DIALOG is satisfaction with treatment. That's the last 3 items. So again, you total the scores up for those, divide by 3, and that's your mean treatment satisfaction score. So you end up for each of these, quality of life and treatment satisfaction, with a score from somewhere between 1 and 7. And higher scores are greater satisfaction. So scores below 4 are dissatisfied, scores above 4 are satisfied, and scores of 4 are neutral. So Stefan Preber and colleagues who developed this measure reported that in 271 people with a schizophrenia or psychosis spectrum, again, average age in the mid-40s, had a subjective quality of life of 4.8 and a treatment satisfaction of 5.5. And again, reasonable psychometric properties, and we're going to be looking at these scores in our first episode psychosis sample and to be sharing those shortly. And finally, the HONOS. So the HONOS is rated on 5 points. 0, a score of 0 is no problem, through to a score of 4 is a severe or very severe problem. And the HONOS, you get a total score, which is just the sum of the scores on all of the 12 items. And in this one, higher scores are more problem. So a minimum total score is 0, the maximum is 48. The higher the score, the more the problem. The HONOS, you can also get some subscale scores for behavioural problems, that's the first 3 items. For functional impairment, that's items 4 to 5. Symptoms, that's items 6 to 8, so including hallucinations and delusions rating. And for social problems, items 9 to 12. And again, you simply add up those scores to get your total. And the higher the score, the greater the problem. Finally, I'm going to be sharing some of the data that we've been collecting from the early youth engagement project that I mentioned earlier. So this is the preliminary HONOS outcome data collected as soon as possible or rated as soon as possible after people were accepted into early intervention services. So we have 740 young people who have a HONOS. and their mean age is 25.4. And in terms of scores, so the average score for the total for HONOS is 13.2 for those 740 young people. And 50% of our sample scored between 9 and 17. So that means, based on this sample, if you have a HONOS total score less than 9, that puts you in the lowest 25% of the population. And if you have a score above 17, that puts you in the top 25% of the population, so those with most difficulties. And the maximum score that is possible on the total for HONOS is 48. So similarly for behaviour, so this is aggressive behaviour, self-injury, drugs and alcohol use. The average rating was 2.6, where the maximum score is 12, and 50% of the population, so half of the people who we assessed, scored between 1 and 4 on this measure. So if you scored 0 on this, you'd be in the lowest 25% of the population. If you score above 4, you'd be in the top 25% of the population. In terms of functioning, so this is cognitive and physical function, the average score was 1.1, and 50% of the population scored between 0 and 2. So if you score above 2, you would be in the highest 25% of the population in terms of functioning difficulties. In terms of symptoms, so remembering symptoms here includes hallucinations and delusions, but it also includes depression and mood and anxiety. The average score was 5.5. 50% of the population scored between 4 and 7. So that means the 25% of the population with the fewest difficulties are those who scored less than 4. And the 25% of the population with the greatest difficulties are those who scored over 7 out of 12 for symptoms. And finally, just specifically on hallucinations and delusions here, so this was just one item on the HONOS. The average score was 2.3 on a scale from 0 to 4, and 50% of the population scored either 2 or 3. So a score below 2 puts you in the lowest 25% of the population for hallucination and delusions difficulties, and a score of 4 puts you in the top 25%. And sorry, the last one was social function, so that includes relationships, activities of daily living, occupation, and so on. So the average score was 4.1. The 50% of the population scored between 2 and 6. So if you have a score of 0 to 1 on this, so almost no problems, then that puts you in the lowest 25% of the population. If your score is over 6, where the maximum is 16, then that means you're in the 25% of the population with the greatest difficulties. So those are based on our own data of 740 young people coming into first episode psychosis services. Those are the kind of ranges and scores that we've seen so far. We've also got a little bit of data on the QPR and the DIALOG, and we've compared that to the published data for older people. So the published data that I mentioned earlier was for people aged 44 on the QPR, and a separate study for the DIALOG people's average age was 43. So these are a much longer term kind of mental health service user population. So the QPR data, 399 people with longer term mental health problems with an average age of 44, their mean score was 38.7 on the QPR. For the DIALOG, in the published papers, for 271 people, their subjective quality of life was 4.8 and their treatment satisfaction was 5.5. So these are the published scores. And now if we look at the baseline scores, so the first scores on QPR and the DIALOG that have been collected in our early intervention services for these young people with a mean age of 25. So they're 20 years younger than the published population, and these are all first episode psychosis service users. We had 419 people who completed a QPR. So this was 56% of that kind of original 740 sample have completed it. Interestingly, the mean is almost identical in the service users with first episode psychosis as it is with the long-term population. So 38.7 in the long-term population, 38.5 in the first episode psychosis sample. So pretty much identical. And in terms of distribution, we found half of our sample had a score between 30 and 46 on the QPR. So if you remember for the QPR, a higher score is a better quality of life. So the people who are doing least well, the 25% of the population doing least well have a score below 30, and the 25% of the population who are doing the most well in terms of their quality of life have a score of over 46. And then on the DIALOG, so the DIALOG, in this case, we had 420 service users who completed a DIALOG. So again, 56% of our whole sample. Again, quite similar measures. So on subjective quality of life in the published data for people aged 43 on average, the subjective quality of life rating was 4.8. In our sample, it was 4.6. So very close, very slightly lower, but not significantly. And 50% of our sample had a subjective quality of life score on the DIALOG between 3.8 and 5.4. So if your subjective quality of life score is below 3.8, you're the lowest 25% of first episode psychosis service users based on our data. And if your score is above 5.4, then that's moving towards the top 25% of first episode psychosis service users based on our data again. And then finally, for treatment satisfaction, the average score for these 420 people was 5.2, which again, similar to, very slightly lower, but not significantly, from the 5.5 average that was found in the older population. And in terms of our sort of spread of responses, so 50% of our population scored between 4.3 and 6 on treatment satisfaction. So that means anyone who scored below 4.3 on this, their treatment satisfaction was in the lowest 25% of the population. And anyone who scored 7, so the top score for treatment satisfaction was in the top 25% of the population. So this is just to give you an idea of the ways in which young people with the first episode psychosis are rating these patient-reported outcome measures and the way clinicians are rating HONOS. We are going to be doing some more work on this, so we're going to be looking at what a meaningful change looks like, and we haven't fully completed data collection, so the exact final mean on our sample is likely to include 950 plus service users in total. So this is just our preliminary data so far, and we'll be publishing a paper later this year, which you can look out for, which will have our final data in it. So that's all I'm going to say for the time being. These are all the people who've been involved in the I2 research team. We'll be able to share more information with you as we get it. And thank you very much.
Hi, my name's Maureen McGeorge, and I'm here today to talk to you about how services improve themselves. Spent many years working at the Royal College of Psychiatrists, developing and delivering national audits and accreditation programmes, and now I work largely in Yorkshire and Humber, delivering training and supports around quality improvement. So how do services improve themselves? Usual approaches to change in complex environments. Often we get one of two approaches. So it's either a kind of very busy trial and error, chaotic approach where lots of people try lots of different things. And the difficulty with this approach is if something works, we don't necessarily know what it was that worked. Kind of opposite to that is the kind of paralysis by analysis. So we get the right people into a darkened room for long enough, we're going to get the perfect solution, but please don't do anything until we get that solution. And we know that doesn't work either. What you have with the model for improvement that we're going to talk about is a trial and learning approach. So what you're doing is testing things out in a very small scale, safe way to work out what it is that's going to bring about the improvement that we're seeking. I'm sure that most of you are familiar with the model itself. So the three questions that we ask: first of all, what is it we're trying to accomplish? Secondly, how will we know what changes in improvement? And finally, the easy one, what changes can we make that will result in improvement? So just to kind of break that down then, and we're going to use an example about poor collection of outcome measures. So really question one has got three separate stages within it. So the first one is being really clear that we understand what's going on, what's causing our problem. Secondly, we might need to do some diagnosis then in order to understand it better, and I'll talk in a minute about different diagnostic tools. Finally, once we've done that, we really understand what's going wrong and how to fix it potentially, then we can start to think about our aims, so the statement of what we want to achieve. Key points then about a problem statement. What we're looking for is something that's nice and short, 1 or 2 sentences, not a great long paragraph, and it shouldn't be judgmental. So it's not second guessing what's going wrong. It's just saying this is the problem that we have. It's not a solution. We often jump to solutions, and it's not a symptom. And the most important thing perhaps is people need to agree that it is a problem. So if people don't think it's a problem, then you've got a problem. You need to, people need to be aware that it's a problem. Otherwise, they're just not going to support the improvement efforts. So diagnosing the problem before you start, a huge number of different tools that can be used for diagnosis. Obviously, you're about to get your findings from the national audit, so you'll have your local data about how you've done on the various different standards. But it may be that you need to generate some secondary data, and there's a variety of different things that you can do, but people tend to overcomplicate it. If you don't know why people aren't collecting data, you might just do a brief survey asking them to write down a couple of reasons why they're not collecting and hand that into you anonymously. There's other approaches you can use, 5 whys. So because we don't often jump towards the symptom of the problem or the solution, 5 whys can be useful. So you might just say, okay, we're not collecting outcome measures. Why? Because we forget. Why do you forget? Because there's a lot of paperwork for us to fill in. Why is there a lot of paperwork? Because we keep getting new forms to complete. Why? Because our paperwork hasn't been reviewed for a while. Why? Because we haven't got round to it. Well, maybe it's a good time to focus some energy around that, because actually by solving that core problem, you're actually going to solve an awful lot more than just meeting the target around collecting outcome measures. Brainstorming. So we talked about surveys as being one way of generating information. If you've got a nice flat hierarchy in your team, it might just be simple to sit down with the team and say, why are we not collecting the outcome measures? Let's have a chat about it. If your team's kind of fairly open to that, but you feel that there might be some voices that are louder than others, it might be an idea to give people pieces of paper to write down their thoughts before they actually share it with the group, to encourage people to make sure their voices are heard. Because the key thing about doing an exercise like this is that it's thinking outside the box and it's not judgmental. So that's brainstorming. Ishikawa is a great tool for either organising data, so you might do a brainstorming exercise and then organise the data around it later on, or you might actually use this as a framework for your brainstorming exercise. And what they say in healthcare is that we should have at least 4 spines on that fishbone. So the first is around people, so the people factors associated with the problem, the place factors, the environmental factors, then there's procedural factors, and factors related to policies. And the nice thing about Ishikawa is it does encourage you to think systematically around the different causal factors rather than just perhaps focusing in on 1 or 2 of those. Finally, I'm going to talk about Pareto. Vilfredo Pareto is an Italian economist who recognised that 80% of the income in Italy went to only 20% of the population. So the law of the vital few and its application in relation to quality improvement work is that if we can identify the 20% of the factors that are causing 80% of consequences, then actually we can be very effective and frugal in our efforts, very focused efforts around our improvement activities. So again, with the example of the poor collection of outcome data, you might do a survey of people. I'd ask them to tell you what the reasons are. You then put them into a simple tally table. You would then put them into a bar chart. It's the only time we use bar charts. We usually use run charts with improvement. But you would stack those on top of each other until you hit the 80% level. You would then know that those causal factors were associated with 80% of the problem that you were experiencing. So if you address those top 3 reasons, you're likely to increase collection by 80%, whereas you could do an awful lot more work around the ones that are more marginal, and you'd only in total be likely to increase collection rates by 20%. So this is very much about helping you to get the biggest bang for your buck. So just thinking through then to an example of the steps applied in question 1, again with the outcome measure example. So you might discover that from your audit that on Ward 4, only 20% of service users had 2 or more outcome measures completed at least twice. The diagnosis, you might use a brainstorming and ask the staff to tell you the reasons, and then you might organise the data using a Pareto to find out what the top factors are for you, where you want to focus your efforts. So on the basis of that, you would then come to the third part of the first question, which is defining your aim. So in this instance, it might be to increase the percentage of service users that have 2 or more outcome measures by 15% by December. The key things we're talking about here is about being really specific about your statement of aim. So you want to know who the population of people are you're going to be working with. So here it's Ward 4. There's a great tendency in doing this stuff to want to work with everybody at the same time. It just doesn't work very well. It's about spreading yourself too thinly. The target, how much you want to improve by, better to underestimate than overestimate, or else the team will feel as though they've failed. And similarly with the time scale, being overambitious can lead people to feeling as though they've let themselves down, whereas just to be realistic. So making sure that it's smart, and also that it's clear and operationally defined. And just a little tip that often when we're doing improvement work, if the aim is stated from the perspective of either the patient or the staff, then it's more powerful and it's more likely to engage people. So really, when you're doing an aim, by the time you come to that point, everybody should have the same understanding and everybody should be committed to actually to reaching that. So just a little bit about choosing your team, making sure you've got the right people around you. So thinking about those who are going to be involved directly or help you access any help, people who understand the system that you're going to be trying to improve, people obviously who are going to be affected by it, so they need to know it's coming, otherwise they're likely to resist you. Who are your enthusiasts? Who are the people that always get involved? And think about active versus passive members. So you might have a very large group of people who are passively involved who are receiving information about the work, but the actual core team might be quite small. So moving on then to question 2 of the model. So this is the bit about measurements, how we know a change is an improvement. So all improvement involves change. Not all change is an improvement, and without measurement it's impossible to know whether you've improved. Great quote here from Charles Vincent, who heads up the MPSA. We treat patients using data. We wouldn't dream of not using full blood tests and other diagnostic tools. But somehow we seem able to intervene in an entire hospital system without data. So what are we measuring? So really there's 3 different types of measurement that we come across in healthcare, and they are very different in terms of their purpose and the utility. So measurement for research, here really we're talking about science, rigor, hypothesis testing, large amounts of data. So people who come from this kind of a background might feel that measurement for improvement is a bit kind of small and insignificant. The other type of measurement in healthcare that people are very commonly associating with is performance management. So here we're talking about comparison, justification, targets, and often the induction of fear in people. What we're talking about with measurement for improvement is just enough data. So again, your research colleagues might struggle with the smallness of the data. We're not talking about meeting targets or comparing anything. We're talking about improving care, and there's ownership by the people that are doing the work. So it's a very, very different type of measurement. The data should be owned by the people that are doing the collection until they're willing to share it. So it's really important to think about your audience when you're doing this, because if they come from a background where measurement is always about performance management, then they may well be fearful of collecting data for that very reason. So different types of measure. Firstly, there's the outcome measure, which relates back to the aim. So if your aim was to increase the percentage of service users that have 2 or more outcome measures by 15% by December, then your outcome measure would be the percentage of service users that have them. Simple. So the outcome measures are nice and straightforward. Process measures. So processes are the specific steps that lead either positively or negatively to the outcome. So it's often times between or adherence to a guideline. So what you're trying to understand here is, are the steps working in the way that you wanted to, and therefore helping you to identify where the improvement efforts might need to be made. And if you don't know at this stage, then perhaps a bit more digging around with diagnostic tools needs to be done before you can move further forward. So thinking about process measures then, if your aim is to increase percentage of service users having the measures taken, and you did a Pareto and it told you that your top causal factor was people being unclear about how data is going to be used, that's going to be a focus of your change efforts. You're not going to get improvement unless you actually get people believing that the data is going to be used in a useful way. So your process measures then might be staff confidence to incorporate use of outcome measures into care planning. So they might not be collecting the data because they don't feel confident about how they kind of make that part of the process. Or it could be about work done to kind of actually express to either staff or to service users about the usefulness of the data, and so you would like measuring that then, because as those things increase, then people will collect it more. So the process measures relate directly to the parts of the system that you're going to try and fix. Balancing measures you may or may not have. They're about the unintended consequences, so the kind of things that people worry about. So you might say, we're going to increase the percentage of patients that have the outcome measures collected. Yeah, but what if they don't feel enough to talk to us about their concerns because we're so busy collecting that data? And the thing is about balancing measures, if you don't collect that data, then people probably won't support you with the work anyway, because they will have that fear that they're actually right. So collect it because they might be right. So just a brief introduction to run charts then. So here's a table that's looking at the delay between a GP referral and appointment with a specialist. And just eyeballing that, I can see that the figures in column 2 are generally bigger than the ones in column 4. Unfortunately, what happened here was that the improvement was made at the end of June, which coincided with the end of the columns. If you put it into a run chart, it's very, very clear that that change occurred. So you can see that prior to June, there was an average wait of about 70 days, whereas after June, they managed to get it down to about 35, 40 days. So that was where the change occurred, but the table doesn't show that very clearly, and the run chart does. Very briefly, the run chart rules. You need to collect 10 data points to get your baseline about understanding how your system's currently operating before you start testing and improvements. So if it's daily data, great. Weekly data, fine. Monthly data, if you haven't already got retrospective data, then you've got a long time to wait before you can start testing changes. So once you've actually got your baseline and you start to be testing out change ideas, if you see 8 subsequent points that are going on the same side of the baseline, then you know that what happened at the beginning of that point led to an improvement. The second rule circled in green, if you see 5 consecutive points that go either all up or all down, they link back to the same improvement, but they show a little bit slower. The link that's there at the bottom of the screen is to an article that explains the run chart rules in very simple but clear terms. So if your colleagues have got a research background and they think that it's all just a bit too good to be true, then that might be a good idea to point them towards that article to read. So measurement, the key messages. Measurements are there to guide improvement. You want to focus on 2 or 3 measures, not lots and lots of measures. You don't want to be drowning in measurements, so the measures need to be important. Ideally, integrate them into routine data collection. So if it's already data that's being collected, fantastic. You need to define your numerator and denominator, obviously, and you're plotting data over time and making your run charts visible so people actually see the fruits of their improvement efforts. Finally, then question 3, what changes can we make that will result in improvement? So this is kind of the easy part, and by the time you get to this stage, because question 1 and 2 can take a bit of time, making sure that you really understand your problem and you've set down your measures, and that all runs along nicely in the background. Then you get to the exciting part. People will have lots of ideas. If they're struggling with ideas, there's always an evidence base. Just because there's guidance around doesn't mean that people are actually adhering to the guidance. There's also people's experiences, and people will have worked in different services where things may have been done differently. They may have been banging their head against that problem for a long time and not really being asked as to how to fix it, so they're likely to have good ideas. The stealing shamelessly, the IHI kind of phrase, is about remembering that that we don't need to go back to the drawing board with everything. We can, if something works somewhere else, we can always test it out in our own service to see if it's going to work for us. And the final one, a really important point, anyone can have a great idea, so you don't have to be senior in the team to have a great change idea. So agreeing you change ideas and testing them. So you're then going to kind of apply the PDSA cycles. So you plan, you do, you study, and you act. What they say in healthcare is we're really good at planning and doing, but we're not then so good at studying and acting. So you have a hunch and you test it out. Then you sit back and you reflect on what happened, and on the basis of that, you work out what it is that you're going to do next. So really what they say is that you have a series of plan, do, study, act cycles, and all the while you're testing those things out, you're learning about what works and what doesn't work. And that in itself brings about a change in the culture of the team. It's important to use PDSAs because they are very much about real-time testing of your change ideas. So because it's small scale, you don't get the same resistance. You're not saying this is how we're going to do it now. You're just saying let's give it a go and let's see what works. You're finding out whether or not it's going to work in the real environment. And they say 1, 3, 5 all. So if you were wanting to develop a risk assessment form, you would sit down, mock up a form, try it out with the next person that came in, sit down afterwards, study what happened, what didn't work, modify your form, test it with the next person that was admitted, and keep going until it was right for you. Then give it to 3 colleagues and get them to test it and do the same thing, and then 5. And they say that by the time you've got it working with 5, then it's going to work for everything. So it's about gradually increasing the rigor of the testing to make sure that something is robust. So very, very different from the kind of paralysis by analysis idea where you kind of expect to come up with a perfect solution straight away. So it's rigorous small-scale testing. And often you get there a lot quicker than you expect because people aren't used to being asked, therefore they've got some brilliant ideas. So just a quick one there about the difference between change ideas and PDSA. So with something like weight loss, nice easy example, because there's only 2 change ideas. You either consume fewer calories or you burn more calories. PDSAs, loads and loads of those that you could try out. So really the change ideas are what you want to do, and the PDSAs are the how you're going to do it. So just some key messages then. We've got bad systems, not bad people. So remember that. It's a very important message when we're doing improvement work. And it's important to have the measurement component in place because measurement actually supports action and people can actually see the progress and they get excited about it. QI, they say that QI is everybody's business. So you should have 2 jobs, doing a job and making your job better. QI can be about making it easy to do the right thing, or it can be about removing unacceptable, reducing unacceptable variation within our systems. And the improvements that we make can be really rapid and really quite profound. But what's great about it is that people get involved and get excited, and it really does change the culture of teams. Here's some links to a few useful resources that were developed up in Yorkshire. So this is the first is an entry-level QI training. So if there's colleagues that are unfamiliar with the language of QI, you can direct them to that. You just register with that, and you can use it free. Similarly, there's an entry-level human factors online that we've developed as well, and a nice video and a toolkit around behaviour change there as well. So please feel free to access and use those. Thank you very much for listening.